Hope Cook here with DermPAS. Today I have Cynthia Trickett. Cynthia is a physician assistant. She's been a PA since 1995. She spent the first 3 years in family medicine, and since then she's worked in dermatology. Cynthia is also adjunct faculty for University of Texas Southwestern as well as UNT. She lectures to dermatology practitioners all over the U.S. On psoriasis and other chronic inflammatory diseases. And Cynthia's been in the U.S. Air Force since 1990.
That's right.
Welcome, Cynthia.
Thank you. I appreciate it.
Yeah, I'm excited to talk to you about psoriasis, especially new psoriasis treatments.
Surely.
All right, so I know there are a couple of new topical treatments out there. And for years, we've only had topical steroids.
That's right.
So what do you think of the new topical medicines?
Exciting, right? There's been a huge treatment gap. Unfortunately, there's just been, this new medicine, and it's a steroid plus something else.
Right.
And we really weren't getting the efficacy that we wanted. We didn't have the safety that we wanted, tolerability, and ease of use. So it's been exciting that we've got 2 new non-steroidal medications, and both of them are once a day. And even in these studies, we were getting PASI 75 numbers. That is unheard of from a topical medicine, right? So very exciting. Now, do I use them by themselves? Sometimes, especially if a patient is very resistant to using a biologic, even though I think they might need one.
Yeah.
But at least I don't have to churn through steroids and give a complicated, use your steroid, this steroid on your face, this one on your scalp, this one in your groin. So these are one-stop shops. You can use them once a day, anywhere, for as long as you want.
And there's not a body surface area
restriction? Yeah, no restriction, but a tube is only one size. So if you've got a larger body surface area and you don't want them to run out of the tube, we'll certainly ask for 2 and give the information to the pharmacist that this person has this much body surface area and these are the areas that the patient has it. That way it's more likely to get covered.
Yeah. Okay, so we have VTAMA and then we have Zoryve. So tell me, how do you pick which one of those to use?
Both of them have their merits, right? Now, if I've got somebody who's 12 to 17, Zoryve is the one that's approved for that particular age group, whereas VTAMA is 18 and up. Yeah, and the data for both of those have different time endpoints. Zoryve is an 8-week dosing to find out, hey, did a person get to clear or almost clear, or et cetera? And then VTAMA was 12 weeks.
Yeah.
All things being said, they're pretty interchangeable. Now, if I've got intertriginous psoriasis, there's great data from Zoryve. Nearly 80% of individuals were clear or almost clear after 8 weeks. And you know how difficult it is to treat. You know how uncomfortable those patients are and how worried we are about side effects. Not only, steroid rebound, skin atrophy, stria, purpura, but also candida, right, in folds. So it's been a breakthrough.
That's exciting. Okay, so what about Medicare patients? That's where I run into issues.
That's tough. Right now, only one of them has a patient assistance program for Medicare patients. Medicaid, they're working on those particular things, but it's unfortunate. The closer I get to Medicare age, the more I realize
close.
And I'm saving for my retirement. Why are people punishing Medicare patients who are saving for their retirement? That's where I'm going to give samples and do my best.
Yeah. And by the time they use 2 little sample tubes, can they see a difference? Is that enough?
Well, it all depends. Sometimes I'll have them use it on one side only to make sure that they're getting tolerability and result. But, I'm probably going to give more than 1 sample tube.
Yeah. And there's no burning, right?
Very little. Very little, right? Less than 5% for both of them.
Yeah. That's exciting.
Yeah, it is exciting.
All right. So then let's talk about the new oral options.
Yes.
Okay, tell me what I need to know if I'm a PA who's been in a closet for the last year.
Perfect.
What do I need to know?
In the closet. Well, we'll be out of the closet. No. So one of the new exciting oral medication options, a DMARD, is a selective TYK2 inhibitor, so TYK2. And for our patients who don't want to be on an injectable medication, we're seeing incredibly good results. And when we even did the head-to-head results, we saw superiority, right, for using this one than our previous PDE4. So it's good that they didn't get any black box warnings, right, because those things make us, step back and take pause and make sure we're choosing the right patients. But since it's so new, I'm being incredibly cautious with it. But nice to know that we're not seeing as many GI side effects with this particular therapy, and we're seeing better response rates.
Yeah, headaches, is that an issue on this one?
Very little.
Okay.
Very little. GI is the ones that we're seeing good, favorable responses there.
Any issues if they've had a malignancy?
Yeah, we don't have data on that, right? I know that a lot of companies are very fast and loose with their data. I'm not. If I have a patient who has had a malignancy within the past 5 years, I'm reviewing it with their oncologist. If it's been greater than 5 years, then I'm a little more relaxed about that. I'll give the patient, this is the medicine I want to start you on, and why don't you give your oncologist a call? Not me calling the oncologist saying, hey, I've got this patient, we've got this mutual patient, and how do you feel about me using such and such?
Gotcha. Do you treat many kids with psoriasis?
I would like to treat more. Mine is mostly an adult practice, but I would say maybe 10% children with psoriasis, and our choices are still very limited. We don't have any oral medications that are approved yet, but we've got some that are coming.
Yeah, I don't see a ton of kids with psoriasis, but I'm always like, I need to go look that up. Are there any go-to medicines that you think of first if you have like let's say a 12-year-old?
Yeah, if I have a 12-year-old and I need to use a biologic, I've got a couple to choose from. Yeah, I've got ustekinumab, and I've also got Taltz, and I've got Cosentyx.
Okay. Yeah. What about a patient with guttate psoriasis, and you've tried oral antibiotics, and it's just not going away?
If I can get them in a light booth, they're going to usually see pretty good results there, and probably would use one of the new topical therapies, even though it's considered off-label because it wasn't studied in guttate psoriasis, but I'm sure I can find a small plaque somewhere and call it psoriasis vulgaris. But those particular patients, I'm usually putting in light therapy.
And if there's no light therapy available?
If there's no light therapy, and I'm asking them not to do tanning beds, that's probably where I would go for using the new topicals that are non-steroidals.
Yeah, those are tough. I live in a college town, and I feel like I see a lot of guttate psoriasis.
Yeah, and especially if they're getting it over and over, then I'm talking about maybe doing a tonsillectomy.
Yeah, good point. Okay, pregnant patients, anything with that?
We're restricted. Restricted. The good thing is, we've got a biologic that is probably my go-to when it comes to Cimzia, certolizumab. But we've got great data for all the rest of them as well, too. So even before it was available, we were using the TNF agents when that's all we had. We were using the TNF agents for women who had severe psoriasis, because that's not good for you. Inflammation is not good for you. It's not good for the baby either, right? Lower birth weights, premature labor, those kinds of things. So if we could get a patient to agree to take and the OB-GYN is on board, we would use the TNF agents across the board pretty much. And now we've got good, the pregnancy classes were taken away from us. Yeah, the FDA took those away from us, and this was right when Lilly's Taltz was being approved. I called the MSL and said, what's your pregnancy class? She's like, they're gone. Oh, what do you mean by that? Yeah, we're just doing registries. But for the most part, all of the biologics are pretty darn safe.
Yeah, okay. And that's off the record. We won't hold you to that.
Okay, perfect. That's the world according to Cynthia.
Yeah, let me see if I had any other questions. So occasionally we have patients that you biopsy their rash, and it comes back as one spot is psoriasis, one spot is atopic derm. Do you have any tricks with that?
Well, I would be very suspect about that dermatopathologist, right? And I would go, what does my clinical experience tell me? I'm going to look at this person from head to toe. It's not common to get atopic dermatitis in the genitalia. Not common, right? If the G-cleft is involved, I'm going to look for my clues on the fingers. And if there's a family history, I'm going to put it all together and I'm going to choose a course. But if both of them came back as psoriasiform spongiotic derm, well, it's true though, garbage in, garbage out. I've got to tell the dermatopathologist, I think it's this. Do the cells match up with this? So I just have to choose a path, right? And then of course you have the an Asian population that often has their psoriasis looks like atopic dermatitis and their atopic dermatitis looks like psoriasis. So you have to use all of your clues and come up with a path. And if it's just not working, well then, rethink your diagnosis.
Rebiopsy too.
Yeah, you could rebiopsy. The thing when I biopsy something that looks like, is it atopic dermatitis or is it psoriasis? I'm saying, is it not cutaneous T-cell lymphoma?
That's a good point.
That's my question.
Yeah. Okay. And do you ask your MAs to put patients in a gown so that their
Head to
skin is
toe.
completely exposed? Okay.
Yep. Shoes and socks off.
Yeah. What kind of exam do you do for psoriatic arthritis? Have them stand up and look at their...
Yeah, no, my patient is sitting on the table,
Yeah.
right? And of course, if I've already done their skin exam and I've already looked at their nails and I've looked in the genitalia, yes. Then I will touch the lateral epicondyles. I will touch the medial portion of their knee. I'll touch the tibial tuberosity. I'll touch the medial malleolus, and then I'll touch the emphasis of the Achilles. If they've complained of any back pain, I'll touch down the upper and lower spine, and I'll touch the SI joints as well too. And you really, I don't know if you heard Dr. Bush speak, he's like, you really only have to use 10 pounds of pressure there. You don't have to, give a death squeeze. If you give a death squeeze, anybody's going to say that it's painful. But you're feeling for warmth. You're asking the patient if it's tender. And I loved what he said about, your fibromyalgia patients hurt between the joints. Your psoriatics and your rheumatoid arthritis patients hurt at the joint.
I have never heard that, but that's a good way to do it.
Yeah.
Okay, so you do that, and if you get some positives or A positive, do you send them to rheumatology?
I will make a suggestion that they see rheumatology, but I'm already instituting therapy because that also helps the rheumatologist because, it didn't work. The rheumatologist already knows that I've tried such and such for, 8 weeks or so, and they're not getting anywhere.
And if you have a patient with psoriasis and they have GI symptoms, you're suspecting they have Crohn's disease or something like that, are there any biologics you stay away from?
I will probably avoid the IL-17s if I can. I will probably choose a TNF first and get them into GI. That's just me.
No, it's so hard sometimes to know which path to take. How do you explain to patients that we may not get it right the first time?
Right. I let them know that psoriasis is very heterogeneous, right? And certain cytokines are your target versus this other person may not be that target. But if there's a family member who's already on the drug and doing very well, that's very because there's genetic what's the word I'm looking for? Genetic likeness with psoriasis. If you come in and you say, well, my mom's on Humira and she's doing great, I'm likely to choose Humira first for you, and that's just whatever drug XYZ, I'm going to choose that one for you first, unless there's a reason that I can't.
Yeah, that is so smart. I don't know why that's never occurred to me. Some patients will mention, my mom is on, whatever.
Right.
Yeah, good point. All right, any tips for people who are new to dermatology and they're totally overwhelmed by all the options and just like, which one do I pick?
Yeah, get really familiar with one from each class and know the merits from those.
Yeah.
Now, all things being equal, if a person has commercial insurance, whatever you choose, you're going to be able to get, even if the insurance company says no. So don't let the insurance company dissuade you from choosing the one that you want first, but choose one from each class.
That's a great tip. It's been so good having you here.
Thank you.
Thank you for joining us.
My pleasure.
Hope Cook signing off for DermCast TV.